Bismillah ar-Rahman ar-Rahim. Amyloidosis. The definition of amyloidosis. Amyloidosis is the extracellular deposition of low molecular weight protein molecules as insoluble fibrils. More than 20 such proteins have been described in different diseases and circumstances. The pathophysiology of amyloidosis. The disease is one of abnormal protein folding and is classified by the origin of precursor proteins that form the amyloid. For example, amyloid AL amyloid forms from the light chains of immunoglobulins. In familial forms, genetic missense mutations produce abnormal folding of the protein. Little is known of specific genetic and environmental factors leading to development of abnormal folding. Despite different origins, protein molecules fold into alternative forms very similar to each other in the classic B pleated sheet structure. Fibrils form in an ordered fashion with uniformity of fibril structure within the sheet. Substitutions of particular amino acid at specific positions in the light chain variable region lead to destabilization of the light chains, increasing the chance of fibrillogenesis. In certain models, this abnormal folding can be initiated by addition of amyloid enhancing factor, rather like the initiation of crystal formation in a supersaturated solution. Amyloid deposits accumulate in the extracellular space, disrupting normal tissue architecture and leading to organ dysfunction, both directly and having space occupying effect. The fibrils may be directly cytotoxic, possibly by promoting apoptosis, and subdivisions of amyloid are largely based on the origin of amyloid protein. The epidemiology. The epidemiology is difficult to define accurately. The epidemiology is difficult to define accurately as the disease is often or misdiagnosed. The age-adjusted incidence is estimated to be 5 to 13 per million person years. The classification of amyloidosis. Primary light chain amyloid AL from immunoglobulin light chain fragments, usually monoclonal due to a plasma cell dyscrasia, a subtype of lymphoproliferative disorders. 1 in 5,000 deaths occurs due to this type of amyloid, and the median survival is 6 to 15 months. Frank myeloma is present in 20% and a subtle monoclonal gammopathy in 70%. Systemic form due to circulating monoclonal light chains, widespread organ involvement, particularly heart, liver, and kidneys. Localized amyloid production by local clonal beta cell, hence heterogeneous organ involvement is seen commonly in the upper respiratory tract and orbit, with urogenital and gastrointestinal involvement. Virtually any organ except the brain can be involved. The secondary amyloid, a AA, which is referred to as AA, a complication of chronic disease with ongoing recurring inflammations such as rheumatoid, chronic infections. The fibrils are fragments of acute phase reactants, serum amyloid A neurological, lung, and cardiac involvement. Median survival is 5 years. Only a small number of patients with chronic inflammation will develop AA amyloidosis, and the time period for the development of the disease is very variable. Other types of amyloidosis, such as dialysis related amyloid, due to fibrils derived from the beta 2 microglobulins that accumulate in the dialysis patients, and inherited amyloidosis due to abnormal prealbumin transthyretin transferrin TTR, damaging neural and cardiac tissue. Last type is organ-specific amyloid such as Alzheimer's disease, in which plaques of beta protein derived from the larger amyloid precursor protein APP protein presumed to be generated locally. Amyloidosis lung involvement. Clinically significant respiratory tract disease is almost always AL in type, though the presence of a strong family history or chronic inflammatory disease may suggest other types. The involvement include laryngeal amyloidosis. Amyloid causes up to 1% of benign laryngeal disease, may present as discrete nodules or diffuse infiltrations, and is usually localized, though can be a rare manifestation of systemic AL amyloid. Deposits are seen most commonly in the supraglottic larynx, presenting with a hoarse voice or stridor, may present with choking and exertional dyspnea that can be progressive or recurrent. Tracheobronchial amyloid, it is rare, 60, 67 worldwide cases reported by mid 1980s. Macroscopically, is either diffusely infiltrative or tumor-like. It is associated with tracheobronchopathia osteoplastica, a disorder characterized by deposition of calcified submucosal airway nodules. It presents after the fifth decade with dyspnea, cough, and rarely hemoptysis. Airway narrowing can lead to atelectasis or recurrent pneumonia. Solitary nodule may lead to investigation for presumed lung cancer. Symptomatic disease is usually localized. The parenchymal amyloid, the most frequently diagnosed amyloid respiratory disease. It is usually divided radiologically into solitary or multiple pulmonary nodules, usually localized AL amyloid or a diffuse alveolar pattern, usually a manifestation of systemic AL amyloid. Parenchymal amyloid lung nodules are usually peripheral and subpleural, maybe bilateral, and more common in the lower lobes, ranging in diameter zero point 0.4 to 15 centimeter. They may cavitate or calcify. Clinical signs are non-diagnostic. The pulmonary function tests may show a restrictive defect with reduced transfer factor. Differential diagnoses usually include fibrosis. Cardiac amyloid may coexist, and distinguishing the contribution to the symptoms of pulmonary and cardiac disease can be difficult. Median survival with clinically overt lung disease is about 16 months, similar to that of systemic amyloid. Mediastinal and hilar amyloidosis, rarely associated with localized pulmonary amyloidosis, and their diagnosis should lead to a search of systemic cause of amyloid lymphadenopathy can also represent localized AL deposition in association with beta cell lymphoma. Pleural effusions occur in 20% of cases with systemic amyloid, seem to be due to pleural infiltration with amyloid deposits. It can be difficult to distinguish between primary effusions and those due to amyloid-related cardiomyopathy. The sensitivity of pleural biopsy in this situation is unknown. Pleurodesis has been tried in some cases. Others, rare reports of ventilatory failure due to diaphragm or other respiratory muscle involvement, sleep apnea from macroglossia due to amyloid. Clinical features of amyloidosis include dyspnea and cough, and non-parenchymal disease may be an incidental finding on routine radiography, and considers the diagnosis particularly in patients with old upper airway symptoms and parenchymal involvement or those with unexplained congestive heart failure or nephrotic syndrome. The diagnosis: histological confirmation is usually required. Congo red stain producing apple green birefringence is encrusted polarized light is the gold standard. Positive histology must lead to immunohistochemistry to determine the fibril type. Histology, transbronchial biopsy, or occasionally open or video assisted thoracoscopic surgery, biopsy more likely if investigation for the solitary pulmonary dual. High resolution computed tomography may show nodule or parenchymal disease. What's called ionized labeled scintigraphy, radiolabeled serum amyloid B, SAB, localized to amyloid deposits in proportion to the quantity of amyloid present, therefore allowing identification of the distribution and the burden of the disease. It is most sensitive for solid organ disease, although the lung disease it can be useful for determining the extent of the disease in other organs. It is expensive and carries an infection risk as the SAB component is currently obtained from blood donors. Laryngoscopy and bronchoscopy may be needed to obtain samples for histology depending on the clinical presentation. Pulmonary function tests to assess the effect of the disease on respiratory function may show reduced transfer factor and a restrictive pattern. Tracheobronchial involvement may lead to abnormal flow volume loops due to larger airway obstruction. Systemic disease, full blood count, biochemistry, and urine analysis, renal involvement. Investigate for underlying blood cell dyscrasia, myeloma, Waldenstrom, macroglobulinemia, bone marrow examination, and search for urine and serum monoclonal protein by immunofixation. The clonal proliferation underlying systemic AL amyloid is usually very subtle, and its identification may be difficult. Echo or cardiac magnetic imaging (MRI) for associated cardiac involvement when CCF is present. Survival is 4 to 6 months. Thyroid adrenal function impaired in up to 10%. The treatment: there are limited clinical trials with which to guide management of respiratory tract amyloid. Management decisions are therefore often made empirically. General treatment depends on the cause of fibril precursor production. That's to say, treatment for the underlying systemic inflammatory condition in AA amyloidosis and treatment of the underlying blood cell dys- dyscrasia in AL amyloid. No treatment may be needed. Local measures may be warranted for endobronchial disease, e.g., symptomatic laryngeal disease, endoscopic excision, CO2 laser evaporation, useful for small recurrent lesions. Stenting can be used. Steroids have no effect on laryngeal amyloid. The tracheobronchial, the tracheobronchial amyloid management depends on symptoms, and treatment may involve repeated endoscopic resections, YAG, yttrium, aluminum, garnet, laser therapy, and surgical resection can be used. Repeated endoscopic procedures are thought to be safer than repeated open surgery. Chemotherapy may be warranted for diffuse parenchymal amyloid if there is objectively measurable disease. Prednisolone and milphalan to suppress the underlying blood cell dyscrasia. More intensive chemotherapy has a better clinical response, but there are few trials. Direct agents targeting amyloidogenic precursors, trans-13, TTR are in the early use. Future developments for treatment. Anti-amyloid drugs are under investigations, including drugs to stabilize the amyloid precursor proteins in their normal configurations and enhance fibril degradation. That's all about amyloidosis or pulmonary amyloidosis, and thank you.